Now we proceed to one of my favorite sections, side effects. Favorite, well, infamous, not so favorite actually, section for service users. So, very important for us pharmacists to understand how to actually approach. And, taking a rational pharmacological approach is a good way to grasp the basics of this. Very firstly, before we proceed, when you talk about side effects, it's not just about listing everything that's on the label, because the label lists the entire spectrum of things that could possibly happen if you take the med. But not everyone is gonna experience all of that. From my limited experience, I'll say that people will generally mention about 3 at most side effects, plus minus, I guess, during clinical encounters. Basically, the principle is they won't experience all of that. Eventually, the downregulation of postsynaptic receptors, tolerance will develop with time, right? Tolerance will develop with time, which also coincides with the onset of action, delayed expression of brain-derived neurotrophic factor, about 2 weeks, right? And another way you can approach this is, I learned this from the late Dr. Michael Wincor, that you can divide side effects into common and the rare serious stuff, which can actually help. So depending on the class of drugs, I can customize this approach a bit, okay? But at the end, of course, sometimes, especially in the serious end, if the symptoms, the tagline, if symptoms persist, don't try to manage it on your own. It might be an emergency. Something as seemingly simple or innocuous as constipation might actually be small bowel obstruction. You might want to have them talk to their doctor immediately, or they could potentially die from that. So if symptoms persist, side effects persist, always have them consult their doctor. The images didn't line up properly. For antidepressants, one way I like to divide the common stuff is to divide them into about 3. Mainly gut. There's a lot of serotonin in the gut. There is a lot of serotonin in the brain. And others. Others, and this one here. Let's start with the very, very, very important other that I always put at number 1. Always ask about sex. And another way, actually, besides the arbitrary divisions I've made, you can divide it in your own way, whichever is more convenient for you. Another way I like to discuss side effects is by going back again to how serotonin works. So if you're talking about, again, serotonin works in different ways depending on the receptor subtype and the location. In this case, 5-HT2 receptors in the spinal cord, sexual dysfunction. So think of serotonin zero tone in where? In the reproductive organs, penis, vagina. So sexual dysfunction can be both for males and females. In fact, this is a major cause of concern for adherents. People are taken by surprise because their health professionals are reluctant to discuss sex with them. And sexual dysfunction can come in forms of arousal, libido, the orgasm, and the resolution after that. So sexual dysfunction can occur in each of those phases. It's very important to talk about that because that can be a make or break for people. So anything that really, this is particularly true for SERT blockers, because again, we're talking about 5-HT2 receptors in the spinal cord. Then, so please don't forget about this. Now for GI, of course, again, lots of serotonin in the GI, 5-HT3 receptors, not just in the gut, but even in the CNS, actually, the chemoreceptor trigger zone. So brain, gut connection, and all of that stuff. So you'd expect the nausea, vomiting, diarrhea. Appetite, this can be due to 5-HT2C receptors in the brain. Yeah, if you recall, usually discussed in the autocoid section. But you mess with that, you can mess with appetite. Yan. So, I should probably move this to CNS now, since this might actually be also predominantly CNS thing. But anyway, again, however you want to conceptualize it, as long as you remember, right? But anyway, take note that this can also have CNS roots due to 5-HT2C receptors, nausea, vomiting, diarrhea, again, serotonin in the gut and in the CTZ, dry mouth, constipation, and all that. Yan. For the CNS, so insomnia, the 5-HT1A receptors and 5-HT2C receptors in the brain can lead to sleep disruption. Okay, here's another misconception. People often think that all antidepressants are sedating. That is wrong. Again, you have to go back to the pharmacology. Generally, an abrupt increase in serotonin can actually lead to disruption of sleep architecture, which can more often than not lead to insomnia, unless you offset it with a mechanism that is generally sedating. For instance, blocking H1 receptors as with mirtazapine, blocking of muscarinic 1 acetylcholine receptors such as paroxetine, or fluvoxamine sigma 1, maybe that's why it's generally sedating, and then TCAs are also antihistaminergic. So, those will generally cause sedation, but say escitalopram, only selective serotonin transporter blocker, and lalo na fluoxetine, it also blocks other receptors that are stimulating in nature, that will lead to stimulation. Generally, those will be more, you will expect more insomnia from that. Okay, so again, this will depend. The insomnia sedation thing, it depends on the drug. It depends on the person din. Some people might experience sedation with escitalopram. So, generally, if it's not more sedating antidepressant, I usually recommend it be taken in the morning. Because, there are some people who realize, like after 3 months on antidepressant, that maybe we should move this to the morning kasi hindi makatulog yung ano. Baka naman inaantok yung service user kasi hindi siya nakatulog the night before due to the med kasi binigay yung med sa gabi. Right? Or posibleng due to the depression itself. So, lots of factors to consider. Okay? Ano na pa? Tremors. So, this will be in schizophrenia and plus D2,5-HT receptor antagonists. When you talk about 5-HT2A receptors in the nigrostriatal pathway, blah, 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 dopamine in the nigrostriatal pathway that can lead to tremors. This is less common. I have personally not encountered this, but it does happen. So do be mindful. Parang it's still possible. Headaches. This bit, it's kind of clear that I really had to re-record. 5-HT1B, 5-HT1D, 5-HT1F receptors. We have meds that serve as agonists for these receptors that when you give them for 1B and 1D receptors, you give an agonist, boom. Vasoconstriction. Vasoconstriction would be a good thing because the blood vessels would not dilate. What happens when they dilate in theory is the nerve fibers in the blood vessels that expand and be stretched, and that will be painful. So constricting will supposedly get less of that. 1F agonists, reduced trigeminal nerve stimulation, reduced release of neuroactive peptides that contribute to the headaches. And supposedly, if you block SERT, you increase the release of serotonin. Increasing the release of serotonin, increased serotonin would then go bind to these receptors. You just bind 1B, 1D, 1F, so supposedly, right? So you get vasoconstriction, right? And reduced release of neuroactive peptides due to reduced trigeminal nerve stimulation. Okay. But why is it that blocking SERT can lead to increased headaches? And so I had to ask around actually there was a very helpful comment actually, which is in line with one of the principles I used to explain this. If you understand something, you have to go back to the basics. Basics being how serotonin actually works in the brain. And apparently some earlier preclinical studies have shown that serotonin can cause both vasodilation and vasoconstriction. So that's a thing. Okay. All of that to say, it's not really clear why and how they cause headaches when the receptor agonists reduce headaches acutely. They're used as abortive treatments for acute migraine management. But yeah, that's psychopharmacology for you. Dizziness, anxiety, 5-HT1A. So again, familiarity with how serotonin receptors work can also help you rationalize side effects. So again, all of these pieces of information, seemingly unrelated, can connect. And those connections can help with the studying a lot better. Yun. Bruising, for instance, due to the 5-HT2 receptors in platelets, you block serotonin reuptake, so platelet aggregation does not occur. So if there's no clotting, then there might be bleeding. So I'll talk about this in the rarer stuff. This is less common din, actually.